Okay, Rohan. So, how will be the video station, Rohan? So you get how
Like
many minutes?
6 minutes. Right?
Okay, 6 minutes for discussion. Prior to that, how much minutes you will be having for watching the video?
So I think 3 minutes.
3 minutes you will get to watch the video, and 6 minutes you will be asked the questions. Okay, and how much marks?
Uh, eight 8 marks.
No, it's the
6 marks.
6 marks. No,
Six,
it's the
six
least.
marks.
It's the least of the all actually, and most often, what type of cases we usually see most often? Why
Usually,
the video station is kept? You need to understand the purpose.
basically some any emergency cases or any casualty like cases.
Okay, so usually it is meant for the emergency. That cannot be kept as a clinical case because of the emergency. The patient might be sick, and that is the reason why it is kept. But now, recently, they are even giving some examination videos also. So it is changing. But commonly, they will keep some emergency cases. Okay. So, Murtaza sir, what are the questions usually are asked?
So first of all, we are asked to describe the findings which we are seeing in the video
Okay.
and put some differentials for it. At least minimum 3 differentials should be put ideally.
Okay.
Followed by we are asked about like what particular history and examination, some specific points we want to ask regarding those differentials.
Okay.
And then what investigations should be done, and followed by management and any like what advice we should give to the parents before discharge. Something.
Okay. That's perfect. So we will be covering. And if it is there in the guideline, the pediatric guideline, most often the content will be the questions, the answers, everything will be from the guideline. So be prepared with the guideline. So that is the most important thing here. So who will do first? Murtaza sir, you will do first.
Okay, sir.
Okay. So others can at the end give your comments and give the feedback to Murtaza sir. Similarly, we will try to practice at least if possible in another 1.5 hours, 5 stations. Let's see if it's possible. Okay. So, sir, you can watch this video. Outside the scenario is a 5-year-old child with painful knee joint. Okay. There will be not much, this much only. 5-year-old child with a painful knee joint and considerable distress. With a short duration. Okay, and it will have a video, and the video you can watch as much as 3 minutes. If there is a audio, it will be written there is an audio. Okay, you will have an earphone to hear that. Okay, so here I will just so usually the full clinical video will be there, but I could get only some pictures. Okay, so kindly adjust with that. Okay, okay, time starts now. 3 minutes.
Hmm.
Will you start, sir?
Yes, sir.
Okay. Okay, sir. So, what are the clinical findings you're
So,
able to make out?
yeah, good evening. I have been given, thank you for giving me the opportunity to see the video of this 5-year-old child, in which I can see both the lower limbs in this case of the child. The knee of the left knee seems to be swelled, and there is redness present, along with some amount of active movement is present in the second video, which I could see. And there is passive movement, which is present in this case to some extent. The knee joint seems to be inflamed. There are no additional surrounding structures which I can see, and there is a small scar mark on the left side of the lateral side of the shin of the knee. The knee looks to be basically inflamed in this case. And as it was provided the history that the child is in distress. So with this, I would like to put my differentials for this.
Okay, so before going to the differential, what history you want to elicit? What all history questions?
So the first most important history for me in this case is the child having fever or not? That's the important thing. Any history of trauma in this case? How are the systemic symptoms, like any weight loss, any night symptoms like night pain in the joints, and the duration of the symptoms, very important. In this case, any history of trauma? Has the child suffered any trauma? And I would also like to take history of hemoglobinopathies like sickle cell anemia and any hemarthrosis or hemophilia and all. I would like to take history of.
Okay, doctor. Anything else?
And I would also like to take treatment option which has been given. Any antibiotic has been taken for this or any analgesics, and how is the response for it? The
Okay,
duration is important for me.
okay, doctor. So, what examination you want to do in this child?
So in this child, I would like to do first the examination of this joint is inflamed. So I would also like to see if the child can bear his weight or not. That's important for me. So, and as I could see, if the amount of active movement in this particular joint, flexion and extension at the knee joint of the leg, and the amount of passive movement which is allowed, and if he is able to bear his weight, I will ask him to walk also and look for his gait, if it is antalgic gait or particular. And if he is not able to bear his weight, I will look for other joints also, if they are inflamed in the body, to like other signs of inflammation of the joints, any other joint if it is involved.
Okay, doctor. Anything else you want to examine?
I would also like to do a formal P-GALS examination, excluding the lower limb, because he is not able to walk maybe due to this. So upper limb, I will see the formal P-GALS. Any rash, skin rash which is there, that also I would like to see, examine him for it. I would like to examine his spine also for the completion sake of his arthritis and those parts to be ruled.
Okay, So so assuming that child has a fever, high grade fever, child is toxic, and there is inflamed and a restriction of movement is there in PGALs. No other joint is involved. So what's your differential diagnosis topmost?
So my differential diagnosis with like a toxic child and fever with this joint involvement single, I would keep a first differential of septic arthritis, osteomyelitis in this case as my first differential, basically.
Okay. Other differentials?
So the other differentials in this case will be articular arthritis, GIA basically, can also be a differential. And traumatic arthritis is also thing, but fever is rare in that case. Other systemic signs and symptoms won't be there, basically.
Okay. Okay, doctor. So assuming that this child has septic arthritis, how are you going to investigate the child?
So first I will, before investigation, I would like to admit this child first and try to keep him oral as my first NBM, basically, because my first differential is septic arthritis, which is a urgent thing. So first I will send the full blood counts for the child to see his how is the lymphocyte count and all. I will see for the inflammatory markers, ESR, CRP, they are expected to be raised in this culture, in this case. I would like to send a blood culture for this before I give any first dose of antibiotic in this case. Then I would like to do a X-ray of the affected limb along with the hip joint also with that and see for any changes if I can see. And if I am unable to get anything in X-ray, I would like to move for a USG examination of the affected limb basically in this case. And if it is sent for like in the therapeutic part for aspiration, then I would like to send for the pus culture sensitivity along with gram stain for it.
Okay, doctor. So what initial steps in the management you will concentrate?
So first of all, I'll alert my multidisciplinary team, which will involve my consultant pediatrician, the orthopedician, along with the radiologist and interventional radiologist, because I might have to do aspiration for it. So we'll involve that. I will inform my OT team with anesthesiologist in the loop, and infectious disease specialist should also be involved. I have already admitted the child and started giving him IV fluids and NBM, and then I will start like IV antibiotics for him,
Okay.
basically.
Okay. So what IV antibiotics?
So my first antibiotic, like if the child is like quite toxic in this case, and the child is around 5 years of age, my first IV antibiotic in this case will be ciprofloxacin, which I will give 8 hourly at a dose of 50 mg per kg body weight IV TID in this case. And after I get a confirmed like culture report and all, I can give the targeted antibiotic for it. And moving
Okay.
for
So how long you want to continue this IV antibiotics? Suppose the child is presenting within 24 hours.
right. So the child is presented to me for 24 hours and he is like fever free for more than 48 hours and the symptoms are recovering. And my WBC counts have started to decrease, like it has started to come below 11,000. My CRP, ESR values are decreasing. So I will consult with my orthopedics team and my consultant, and then we can plan for making it oral. And for oral, I would like to give co-amoxiclav in double its dose, basically.
Okay. Okay. Thank you, doctor. Thank you.
Yeah,
Time
thank you, sir.
almost 1 minute extra, sir.
Oh,
But how did you do?
don't know. I didn't give much differentials, I think. I was stuck with not much differentials. I
Okay.
think.
So maybe one thing which you can work on is differential. Okay. How about others? Others can give your inputs. Anybody else wants to give inputs? Rokshna? Okay. Okay. So I would say, Murtaza sir, it was good. So you used your guideline you came to the diagnosis, you kept a differential, and you kept on asking the right questions. So I would also suggest for, I think we have a comment, very well prepared and coherent presentation. So yes, even I felt that it was good. Uh, Not much I could pick up. So good, sir, good. So in the differential diagnosis, what I always suggest is to write down the differential diagnosis first itself at the initial uh, 3 minutes when you're watching the video. So maybe you take 1 minute to watch the video and 1.5 minutes, and remaining 1.5 minutes you write down your differential diagnosis. From that differential, try to prepare the questions which you are going to ask. Try to prepare the examination findings which you are going to check for, and then the examiner will give you the findings. Based on that, you arrive at a diagnosis and then move on with the investigation and the management. So did you keep all in the differential, sir? So what all we missed? So one is septic arthritis, osteomyelitis, fine. Trauma you asked. How about non-accidental injury? Did you keep?
I did not keep it as a differential. That's important, right? In any age group, right?
Because MRCPCH, no, so they always concentrate on these things, the non-accidental injury. Okay, so whether you're a safe doctor or not, so whether you are not missing out on the other important things. Okay, so one is non-accidental injury. Plus, did you keep other arthritis? So it's an arthritis, right? So septic
Right.
arthritis, okay. So other arthritis, so could it be rheumatic arthritis, 5-year-old child?
Yeah. For that, like the history important, like
Ah, so that
cutting
so
move,
you can build
breathing move.
on the history. So
Right.
when you keep the DD, I'm not saying it's rheumatic, but
True,
when
true.
you have this in your differential, you can easily ask it in the history quickly. But you kept the hematological with you. Malignancy also you kept it. You asked about the fever, weight loss. Okay. Then in the feedback, if I would say to start with, always what questions you will ask. Actually, you straight away went to the fever part. So anything, any complaint. So what will be the initial questions which you will ask in the elaboration of
Like
this?
duration of the
Ah,
symptoms, how is
ah,
the progression, relieving aggravating factors.
yeah, yeah,
Those.
yeah. So to start with, you start with like that. So what is the onset? How long it has been there? Is it worsening or not? What aggravating? What is the relieving factor? How about anyhow the generalized features? No, fever, activity, sleep, weight loss. So these four things, if you standardly ask, anyhow it will be helpful for this also. So you will not miss out the septic arthritis. So you start with that, then, depending upon the DD, you start asking one by one. So, septic arthritis. So, is there any fever? Then, how about the joint? So, joint swelling, decrease in the movement, pain. How severe is the pain? Then, is it disturbing the activity? How much can he walk or not? So, I think those things you can ask. Then trauma, I think you can ask. Then non-accidental injury. Related to non-accidental, what questions can you ask in the history, sir? Mustafa sir?
With relation to this, like the duration of symptom in those cases, like the duration won't be much, and the presentation to the hospital might be delayed.
Okay, so it's not correlating. So is there any delay in arriving at the hospital? So maybe that, and you can even straight away ask the parents, is your family registered to the social services? So I think that history you can ask. Okay,
Okay.
so maybe his father might be, would have brought, so father might have had some issues. So is your family registered to the social services? So that you can ask. Then related to the arthritis, although it's not there, but still reactive arthritis is a DD, at least in the DD you can ask. So any history of recent URI, so that you can ask. But many times it will be more in the hip region, so the transient synovitis.
Right.
But lines is definitely a possibility in UK. So history of travel to an endemic area, so that you can ask. Then related to JIA, maybe at least it will not be so red, but still history of any early morning stiffness. So like that, you can ask 1 or 2 questions. It's only history, no? So you can ask those questions. Then related to septic arthritis, so maybe the vaccination status will be useful because depending upon that, the organisms will change. Related to the malignancy, I think you asked in the right way. So whether any fever, any weight loss is there, any night bone pain, which is waking up the child in the night. So it could be bone malignancy also, no, somewhere around this bone, or it could be a leukemia which will have the bone pain. Similarly, you can ask the 3 cell line affection. So any history of any bleeding tendencies. Okay, so bone pain, bleeding tendency, any bumps, any lymph nodes, so that you can ask any swelling. Then hematology, definitely sickle cell can present like this. So any known history of any chronic disease related to the blood, so anything of that nature, so you can ask. So in asking questions in the history fast. So almost you picked up everything, but only the I got disconnected actually. I'm able to hear.
Yeah, we can hear you, sir.
Just okay, 1 minute. Screen visible?
Yes, sir.
Yes.
Okay. So examination wise, I think how do you start, sir? To start with any examination standard, you keep this one line.
So
Start
just
with.
general physical examination we will start. We'll
Uh,
see for uh, like any lumps, bumps, if it is there, any.
no, before that. So what is the vitals? So because
Yeah,
this is a sick case, right? So
true.
video station is meant for the sick case, no? So I would look into the airway, breathing, circulation. How is the vitals? So maybe the anthropometry. So you standardly you start with that. Okay. Then here you are straight away the hydration status you are looking. Then you can here you are very clear that there is a swelling. No, so I think there you can straight away go to the swelling region. So musculoskeletal. No, so swelling region. Did you describe the swelling? I think at the end you said the P gulls. No, so P gulls is okay. How about the joint swelling? So what all will you examine when you have a joint swelling?
So we have to examine that joint and the joint above it,
So
basically.
what all? So what is that format?
So for that we will see for the like joint swelling which is there. It's any tenderness, swelling, limitation of movements like active and passive both movements we will see in that. And
Yeah. So look, feel, move.
look, feel,
So general
right,
physical examination. Then your look, feel, move. So that and you are looking into the restriction, pain, tenderness. So that all you are going to look. Okay. Then what else you looked, sir, other than this? So that's swelling. So other areas you are looking. How about JIA and other rheumatic? So what all we are going to look for that? So we have to look for at least spine, you said. So eyes, skin, nails. So any musculoskeletal, I will examine the eye, skin, nail so that you can
right.
ask.
Right. Right.
Then malignancy. So we had leukemia in our DD, no? So what will be your next
Hepat
assessment?
hepatosplenomegaly, if it is
So
there, maybe then
abdominal examination. So you do the abdominal examination. So
lymph
you keep
node.
your DD, you keep thinking in that DD, you will get the history, you will get the examination. Okay. But concentrate on what is most important. So here septic arthritis is most important. So concentrate on that. Okay. Then we asked, what is your differential? What is the topmost differential? So how will you differentiate? I think you picked up that important red flag sign, no? So weight bearing. So whether the child is able to weight bear or not. So that's very important. So then otherwise, investigation part. Actually, I had a small when I asked what investigation. So you did the right thing by saying that before investigation, I would like to admit the child. So that's a very important. Those small things which the examiner will be very happy. So I'm very concerned about the child rather than investigation. So I would like to admit the child. I would like to inform the consultant, and I would like to keep nil per oral. I would like to inform the orthopedician. I would like to inform the anesthetist. I would like to inform the radiologic intervention. So those are very important things before jumping onto the antibiotics. Then investigation, you said very well. Very important is the culture part and all the inflammatory markers. So you did. Then, if aspirate is then that I have to send for the culture. So that also you told correctly. So I think then imaging also you brought nicely. So I would like to do the X-ray, then ultrasound. And if you feel you don't get anything much, then MRI also you have to do. Okay. Treatment also part also very good. So you start with what important you will start with in the management? Nil per oral you said, IV fluids you said, then third one what? Third, fourth, before antibiotics.
Analgesia.
Analgesia, very good.
Analgesia.
So pain management. So analgesia, even up to you have to go up to the level of opioids because of the pain. You have to go up to the level of opioids to help out the child with regards to analgesia. Then you are starting the antibiotics. So based on the protocol. So for this child's age, based on, I think that much only time will be there. So 5 years, I think, right? You talked about cefuroxime. And if the child suppose is sick, I think you know ceftriaxone. Then above that, you go for flucloxacillin. And if there is anaphylaxis. So it's all in the guidelines. So you just read out. Just how long will you give IV antibiotics? So that all you picked up very nicely. So if presenting within 24 hours, then maybe within 72 hours, if the child is better, I will move on to oral antibiotics. But if the child is presenting after a period, after a delay, then you are doing a proper debridement, then you have to give it for 2 weeks. So that's the thing. Okay, good, sir. But overall, it was good. Already you are ready for your exams, I think. Okay. So
Thank
next, thank you. Okay, we will move on to the next station. Rukshna, you're there?
Yes.
You are ready? We'll start.
Yes.
So, okay, ma. So, almost a similar scenario, but somewhat different, slightly different. So, you're entering inside. So, take your 3 minutes.
Are you able to walk for me? Could you try? That's a good boy. Are you able to walk for me? Could you try? That's a good boy. Are you able to walk for me? Could you try? That's a good boy. Are you able to walk for me? Really dry. That's a cool. Are you able to walk for me? Really dry. That's a good boy.
Can I start?
Yeah, doctor, you can start. So, what can you observe? What clinical findings are you able to observe?
Yes, in this video, I can see 5 years old child in a hospital settings. He is non-dysmorphic, appears to be well grown for his age. However, I do want to do the anthropometry, and he has in the video I can see that he has antalgic gait. His strength phase is reduced while walking.
Okay, doctor. Can you see any swelling?
No, I can't appreciate any definite swelling, any skin surface reveals there's no bruising, no PTC. I can't appreciate.
Okay, doctor. Okay. So, what history you want to ask, doctor?
Yes, onset, is it associated with any pain and duration of is progression of this? Is there associated with any kind of fever, weight loss, daily activity, any history of upper respiratory cough, any history of loose motion, any history of trauma, and also any social history and family dynamics and impact of the disease on his life and family life.
Okay, doctor. Okay. So, what examination findings you are planning?
General examination, vital sign, and musculoskeletal examination, pegals, and also do the look, feel, and movement, and examination for the leg length discrepancy present or not.
Okay. Anything else?
And skin survey examination for any bruising, any features of non-accidental injury such as trauma or torn of the frenulum, any unusual bruising.
Okay, doctor. So, what's in your differential diagnosis? What differential diagnosis in your mind?
It may be septic arthritis, reactive arthritis, osteomyelitis, non-accidental injury. Hematological case, maybe it's a sickle cell disease, hemophilia, and also traumatic injury, initial presentation of GIA, rheumatic fever.
Okay, doctor. Okay, so assuming that this child doesn't have much of a fever, the child is not toxic, it's a short history. Child had a recent URA 1 week back. So what will be your top differential?
It may be case of reactive arthritis.
Okay, so what red flags are there to
Yes,
say against which you should
yes.
consider red flags?
If red flags are if not able to weight the beer, not able to bearing weight, and bilateral involvement, and and also weight loss.
Okay.
Yes.
Okay. Okay, doctor. So how do you want to investigate, assuming it how do you want to investigate?
Yes, if is reactive arthritis is my initial diagnosis. So baseline investigation, full blood count with ESR, CRP, and X-ray of affected joint in anterior-posterior view. And to exclude other differential diagnosis, blood culture, and also
Okay. Okay. So how do you want to manage this child?
yes, after taking focus history, examination, and sending investigation, I will involve my consultant, and I will review his previous report, and also start analgesia, reassurance the patient, and then I will tell when to come back whenever there is any red flag present, and keep the child in rest.
Okay. So you are reviewing the child after 5 days, and still the child is not improving. What will you do?
If child is not improving, so after 5 days, I will consult with orthopedics.
Okay. And suppose the child is improving.
So if the child is improving, so I will continue the treatment and come for follow-up.
Oh, okay, doctor. 6 minutes over.
Okay.
So, Rakshana, how you did?
I tried, but possibly in the management plan, I don't tell about according to the guideline.
Transient synovitis, not much is there actually, but otherwise you picked up. There were a lot of points they were discussing. Wait, no. So whether it is a Trendelenburg gait or entalgic gait. So I think you picked up right now. So it's an entalgic gait, and that's very important actually. So differentiate whether it is Trendelenburg and entalgic, and based on that only our DD. And after that, same has written that it's DDH. Yeah, if it is a Trendelenburg, then DDH will come into the picture. So
Sorry, can I say it's limping gait?
it's limping gait, but limping can be because of either way. No, it can be also antalgic, also painful gait, also will be limping. Similarly, the weakness related gait, no, so the Trendelenburg gait, that also will be limping. So antalgic means the child is in considerable pain. So that's why if you say antalgic, that is better. But limping, you can say, if you are not very sure, you can say limping gait. Okay. And voice is breaking. Okay. So, so any other feedback?
It was such a nice presentation. One DD which they put in male child with limping is like testicular torsion. That also we should like keep in mind.
Okay, so good,
Male child.
good. So I think we can, because if you try to tell that also after covering all the regular things, I think they will be accepting it in a good manner. Okay, so my DD. So did you include all this, ma? Rokshana? So septic arthritis, reactive arthritis. So I think the whole thing MRCPCH, no. So they want to keep common is common. So reactive arthritis here will be your predominant. But whether you are not missing the septic arthritis or not. So that is what they are going to examine here. Okay. Then you gave all the arthritis, other causes, JIA, rheumatic, Lyme's. But did you ask it in the history? You kept it in the DD when I asked. Rokshna, are you there?
No. Yes, I'm here. No,
Ah,
I'm not. Yes, ask about the. I asked upper respiratory infection in the cells of reactive arthritis.
so that you asked. Because
Yes.
so that's why I say again also. So you write your DD at the before the 3 minutes itself. Write down all the DD and maybe what all questions, one or two questions for each of your DD if it's relevant. So do not miss out on it. Okay. Then it will be easier because in the DD you gave Lyme's disease, JIA, rheumatic. Because this can be very well be JIA. No. So you have a painful, not much swelling, happy child. The child is not toxic, no. So it can be very well JAA. So whether there is an early morning stiffness, so all those things we have to ask. Similarly, it could be Lyme's also. So he will have only the travel to the endemic area, any rash. So any rash history you should ask. So those are important. Similarly, rheumatic in developing countries, I think, doctor. In developing country, rheumatic we have not supposed to miss out. So whether other joints, the migratory nature, how about other features are there or not? The skin rash, so the involuntary movements. So that all, if you say, that would be important. But most important, I think you picked up the NIA, so non-accidental injury. So do not miss out the non-accidental injury. And trauma, history of trauma, you are going to ask. And in the DD, when they ask you the DD, Rokshna, did you talk about Perthes?
No.
Yeah, it's very important, no?
Yes, in this age.
Yeah, 5 years plus, no? So Perthes, do not miss out. Similarly, after 10 years, then slipped capital femoral hypophysis. If more than 10 years, keep that in your DD. When it comes to investigation also, so suppose adolescent girl or adolescent, no, overweight. So then the view, all you have to say, the frog lateral view, so that you have to talk. Then neoplasia, you didn't keep neoplasia in the DD?
Yes, for weight loss, fever, weight loss,
Okay.
and night sleep.
Okay. If you asked, well and good. And in but abdominal examination you didn't do. You,
Yes,
you,
yes.
you didn't do, no? So keep the same in the same parallel you keep doing. So neoplasia, what in history I'm going to ask, what in examination I'm going to do. Okay. Hematology also you picked up I think sickle cell and hemophilia you asked, so that's good. And but also keep some amount of the Trendelenburg type of, no, so non-antalgic causes also in your DD. So because it's in the history, no, you are in the history, so keep that also. Maybe one or two questions you can ask. So how the delivery, what was the newborn screening for hip, was it done or not? What was the result? So maybe one or two questions you can ask. Although it's clear cut, it's antalgic, no. Then related to examination, okay. Red flags. So any other, you talked about weight loss as a red flag. Anything else you think of as red flags in a child with limping gait? So the lymphadenopathy, hepatosplenomegaly. So I think that with weight loss is okay. Suppose you have joint swellings, joint pain in multiple joints more than 6 weeks, that also is considered as a red flag as per guideline. I'm just saying the guideline. If there is more than 6 weeks of joint, no, so there JAA is a red flag. Similarly, more than 9 years, then again you have hip movement, no, you are suspecting Sufi, that is also a red flag. Weight bearing, you told, that is a red flag. Fever, you said, that's a red flag. Similarly, malignancy. So they are expecting these to be ruled out. Even though it's a reactive arthritis, do not miss out on the non-accidental injury. Do not miss out on the septic arthritis, and do not miss out on the malignancy, and here one more is Sufi. They are keeping as a red flag. That's okay. Then management part. I think all three you told. I will give analgesics for the pain relief. I will give a information leaflet. I will tell the danger sign when to return back. So I think you picked up everything right. And just you are reviewing back 5 days. So that question only, as per guideline, I will tell you. Suppose there is no much improvement. So what will you do, Rokshana? So there is no improvement 5 days after they have come.
So I will refer to the orthopedics,
Okay, but
or I will
if
take the opinion of them.
but the diagnosis is transient synovitis, no? So it might take some more time, right?
Okay.
So
Yes.
if it's not worsening, no, then you need not refer. You can again review back another 5 days after. So this is what in the guideline is given. But if there is worsening, then you take the help of the
Orthopedic side.
orthopedician. But again, you are doing the second review, still not improved, then take ortho as well as rheumatology opinion. So this is as per guideline. Uh, the language in video station is very clear. If there is something in the guideline, it will be from the guideline. The questions will be from the guideline, and whatever you say, they will accept it as per the guideline. It is the common language for the examiner and the student to interact. Otherwise, no. So every book will have something or the other points, no. So in order to interact in the same language and to give you more marks, that's why they are following the guideline. Okay. And what questions? Acha. There are some questions. What are the questions for Pertis and Sufi? I think most of them have asked. I think for Sufi, it's simple. The age is very important, and obesity. Is the child overweight? So that can be a important question you can ask. Then
Growth hormone.
uh, taking of any medication, especially growth hormone. So I
Or
think
hypothyroidism.
hypothyroidism. Okay, good. Perthes, I think not much risk factor. I think the age is the risk factor, and imaging will pick you up. So there will be an antalgic gait, and the age is very important. And not much. You don't have any reason for why Perthes happens also. So there will be limping gait in the 5 to 10-year-old group, and when you do, you will get the avascular necrosis. So that's how you pick it up. Okay. Okay. So next, Rohin or who wants?
Sangeeta, me.
Sangeeta wants to do. Okay. We will give it to our guest, Sangeeta. Okay, ma. So this gate, you see, it will be a bit slightly different to what we saw before, and some small adjustments you have to do when you are doing your discussion part. Okay, so take your 3 minutes time. I think the video is not clear. Now it's clear. Okay, ma. Sangeeta, you want to do? Ready?
Yes. In this video, I can see a girl who is walking with the Tindelberg braid. Girl is also looking thin. I would like to plot his height and weight on appropriate centile chart. And I can appreciate there is a swelling on right knee, but I would like to do a closer view of that.
Okay. So, what type of history questions you want to ask?
I would like to ask when this kind of walking is start and how it is progressing. Is it increasing or it is having any pain associated? Is there any history of fever, any joint pain, difficulty in joint movements, and also any back pain? And also would like to know about history of trauma.
Okay. Anything else? You want to add anything else, doctor?
Um, any any weight loss history, any change in sleep pattern history, and also would like to ask about any bleeding issue having in a family.
Okay, doctor. So, what examination findings you want to do, doctor?
So first of all, I would like to, as child is looking thin, I would like to measure height and weight, and also would like to do a detailed musculoskeletal examination, including piggle with right knee, checking range of movement, and detailed knee examination for any swelling, tenderness. Look for the joints and feel for the any effusion, and also checking the movements.
Okay. Anything else you want to do, doctor?
Also would like to check abdominal for any hepatosplenomegaly, and also would like to check lymph nodes and rashes.
Okay, doctor. So, suppose the child doesn't have any pain, and this has been there for a long duration since the child started walking. This limp is there. Okay. So, what's your top differential diagnosis?
It can be developmental dysplasia of hip.
Okay.
Uh, and according the age, I would like to keep as a female child, and I also would like to keep any non-accidental injury, abuse, and trauma.
Okay. Okay. So, what clinical features you expect in a case of a developmental dysplasia of hip to make a diagnosis?
Um, Delayed walking,
Okay.
and also there is a thigh having increased skin fold thickness,
Okay.
and also limb length discrepancy.
Okay. Okay, doctor. So, what investigation? So, assuming that this is a case of developmental dysplasia of the hip, so what investigation you want to do for this child?
As, as child is now approx 5 years of age, so we are doing X-ray, and also would like to do detailed hip examination on bilateral side.
So, X-ray of the what region, doctor?
X-ray of bilateral hip joint.
Okay, X-ray of the hip joint. Suppose this is a newborn. So, what investigations you want to do?
For newborn, we are going for ultrasound of hip.
Okay. Any clinical test is available in the newborn?
Yeah, we have to do Barlow and Ortolani test for newborn at birth, so we can rule out DDH.
Okay. What complications can occur if DDH is left unattended?
Most common complication is delayed walking
Okay.
and deformed gait and also long-term walking difficulty. So child require any arthrosis and other supportive treatment for that.
Okay, doctor. So how do you want to manage, treat this child?
So as the child is already more than 5 years of age, I first of all I would like to involve my consultant. Also would like to involve the orthopedician team. As the child having a difficulty in walking, so would like to involve orthosis. And if any pain while walking, then we have to give a analgesia SOS. And also would like to involve physiotherapist here.
Okay, doctor. So what non-medical management and what definitive management available?
For definitive non-medical management, we have to explain parents about the what is the condition and how next plan of treatment with involvement of the orthopedic team, and also we have to give a corrective shoes and also supportive equipment for walking,
Okay.
and
Surgical?
corrective treatment is a surgical management.
So what they are doing, they will be doing?
Currently, I don't remember it.
Okay, doctor. Almost already 1 minute extra over. So, Sangeeta, you're from which place, no?
Ahmedabad,
And,
India.
okay. So how you did?
Actually, I didn't pick up DDH early. I even didn't kept in my DD.
Hmm. Yeah, but almost you got the diagnosis right, no? So the moment you get the diagnosis right, half the marks you get actually. So 3 marks you got. Okay. Then almost you took it well for the way. Just other inputs anybody wants to add? Srikanth, Rohin, Murtaza sir, anybody wants to add to it?
I think she missed complications, sir. If it is a DDH, avascular necrosis of femoral head.
Yeah, that's good. So
The
maybe
non-surgical part, non-surgical part, braces, splints like Parlic harness.
yeah, Pavlik harness. Good, good. So
For
the
DDH,
Because
only one question here. If DDH, I will ask about birth history or no need.
yeah, I think in the history, no, no, Sangeeta, in the history, no?
Yes,
Birth,
breach and birth history and first female child and any similar family history.
yeah. So all the risk factors now you are telling, no? So that all you can ask in the history. So that's what,
Yeah,
no?
got it.
You keep them in the DD. So you're keeping DDH in the DD. So then the birth history is very important. Okay. Then anybody else? Anything else you want to add?
Yes, in the gait examination description, that gait examination reveals that the hip is dropping bilaterally in each step, demonstrating its waddling gait.
But is it bilaterally she's doing? I felt it's only one side. To the left side, I think, no? Mainly the
Okay.
unilaterally, the left side she was doing. Mhm. But
Okay.
that difference is very important. Actually, she picked up rightly the Trendelenburg gate. So that's why I wanted to give you the two different gates. Previously, we had the Tentalgic gate and now the Trendelenburg gate. And slowly the discussion went away from the septic arthritis. But you cannot be totally neglecting septic arthritis also, because it's a red flag, no? So you should not miss out. So in the history, you are going to ask those things all, but relevant to the chronic condition, history needs to be asked. I would say, Sangeeta, that there some extra questions you could have asked. So it's more of that septic arthritis questions only you have asked. So what is the onset, duration, progression? I think that was fine. Fever, joint pain, that all will be in the septic arthritis, because it's not the antalgic type. There is no pain at all, no. So you can ask, but maybe you will not get much in that. So weight loss, bleeding history, all those will be for the septic arthritis, leukemia, antalgic part. But here there is a
Yes.
chronic condition. So that related some questions you should ask. Okay, as rightly said, the birth history, what was the presentation? Okay, developmental history, was there any bottom shuffling? So those things can be there, no? Bottom shuffling, development can be delayed. Then birth history, beach breach presentation. What was the newborn screening results? So there, some history you should move away from the septic arthritis. So that alone, I would say one correction. Um, Otherwise, in the DD, 1 minute. I'll just show. So we kept the DD. So rickets, sometimes even you can keep when it is a Trendelenburg, no? So muscular dystrophy, as
Yes.
Roshni said, if it is a bilateral, then definitely the muscular dystrophy. So history should be related to the delay in the motor delay, birth history, what was the breech presentation,
Gover sign.
Gover sign. When it comes to examination, you could have done the Gover sign, etc. Okay. And nutritional history also important. Sometimes rickets can also present like with some gait abnormality. So take some nutritional history, perinatal history. What were the results of the hip screening? So that all you can ask. Okay. So otherwise, it was okay. Just you have to ask some questions related to your chronic conditions. So that's it.
Got
Similarly,
it.
when it comes to examination, also same thing. So in examination, what are actually I asked you, what are the clinical features of DDH? That time you told everything. So that you should have put in the examination. So in the examination, you should have said, I would look for limb length discrepancy. Have you heard of this Galeazzi sign? What is Galeazzi sign? Alice sign. Galeazzi sign.
I could not remember right now.
So anybody wants to tell that Galeazzi sign?
Unequal levels of knee joint, I think, sir. When hip and knees in the flexed position,
Yeah.
so need to check the level of knee joint, bilateral knee joint.
So that will be unequal. So that suggests that there is a developmental dysplasia of the hip. So when DDH is coming, then you are looking for the limb length discrepancy. Then you are looking for the spine. Then when you are looking in the behind, how is the gluteal fold? Any excess fold is there or not? Then you are looking for the Galeazzi sign. Then sometimes you might get a newborn video also. Then you talk about the Ortolani and Barlow test. So somewhat you have to move away from the septic arthritis and towards DDH you have to give your examination findings. So that only my one feedback. So depending upon the condition, you have to ask. Then
Okay, got it.
neurological examination, because muscular dystrophy and other
Yeah.
proximal myopathies, no? So a neurological examination I will do, so that you can do. Investigation, I think fine, you got it right. X-ray, hip, you will tell. The complications as suggested by Srikanth, no? So you have to talk about the osteoarthritis, avascular necrosis sometimes happens, coxa magna, no? Sometimes the head becomes a bit abnormally large. And treatment also here, the multidisciplinary, just like the CP and chronic disease, no, the multidisciplinary team approach you have to bring. I think you brought the physiotherapy well, so that was good. Similarly, liaise with the school, orthopedician, pediatrician, so all those you can bring. And non-medical, I think lightly said, you can talk about Pavlik harness. Surgical, actually, more than 2 years, the reduction, no? So you do the closed or open reduction if it is more than 3 months. If it is more than 2 years, not only reduction, you have to also do some construction for the femoral head. So femoral osteotomy, like that you have to do. But okay, if you are unable to do, you can just say I will take help of the surgical team. So, okay. So then we will move on to the next question. Who wants to take next? Srikanth
Sir, okay, sir.
will take. Okay, ma. So take your 3 minutes. If you
Okay.
finish early, you can start early also, no problem. So here is a child, young child, toddler, presenting with difficulty in moving of the upper limb. And
Okay.
she considerable pain.
So the first technique is one hand to monitor the radial head. With our other hand, supinate the patient's arm. Gentle traction. Go ahead, give a second. If you feel obstacle system, go ahead. Hyperextended. Do the same thing. You're hyperextended as you fully supinate. Well, now you're doing the hyperpronation once. So the first technique we use is one hand to monitor the radial head. With our other hand, supinate the patient's arm. Gentle traction. Go ahead, give a second. If you feel obstacle system, go ahead. Hyperextended. Do the same thing. You're hyperextended as you fully supinate. Well, now you're doing the hyperpronation.
Okay, you want to take pa?
Yes. Yes, sir.
Okay, 1 more minute is there, but we'll start early. Oh.
Okay, sir.
Okay, doctor. So, what are the clinical findings?
Hi, good morning. I can see one in the video, a female child is there in the hospital setting. I think there is no dysmorphic features, but she is in distress. I think she is well grown for his age. However, I would like to plot his centiles. People are doing some reduction technique by following the orders of consultant. I can see these things in the video.
Okay.
Mostly in left arm. They're doing some reduction maneuver in the left arm, left side.
Okay, doctor.
I can observe that her limb is in adduction position and elbow in pronated position and near to his her body. I think flexed position and pronation and adduction.
Okay. So, what questions will you ask in the history?
So I will ask about symptom duration. Duration of the symptoms. Any history of trauma. I would like to ask any recent event, or I would like to ask about what child is doing before the episode, and how she is using the limb. I want to ask all these questions in the history.
Okay. Anything else
Yeah,
Anything else?
history of trauma, sir. Any uplifting of child by hands or wrist, or swinging at home before the incident by the parents.
Okay. Then, okay. So what in the examination you want to do?
So I would like to, first of all, I would like to take vitals, and I would like to examine her upper limb. I would like to check of signs of infection like pain or tenderness, any swelling. I would like to see for any deformity, and I would like to check her brachial pulse and radial pulse. I would like to check her color of the upper limb.
Okay. So what is your differential diagnosis?
Uh, Now, my differential, by seeing all these positive things in the video, I can say that patient is suffering with nursemaid elbow, or we can call it as pulled elbow. Uh, Maybe other differentials like fracture, mm,
Okay.
mm, fracture of humerus. Mm,
Okay, doctor. Okay.
sir.
So what investigation you want to do?
So if it is a case of a pulled elbow, uh, there is no requirement of any investigations. It is a clinical diagnosis. If I am suspecting any fracture or any non-accidental injury, I would like to do some investigations like imaging, X-ray of the uh, elbow joint with the forearm at AP and lateral view. At the same time, I would like to send for bloods like coagulation profile and full blood count.
Okay, doctor. So how do you want to manage this child? Right.
First of all, I will admit the child. I will take her vitals. I will, as it is a orthopedic condition, I will involve my I will approach the child with my multidisciplinary team. It will include my pediatric consultant. At the same time, I will involve my orthopedic surgeon mm, for the further management.
Okay. So what is the definitive management?
Definitive management is reduction of the nursemaid elbow.
So
It,
how will you do that?
so it can be done by two techniques, sir. One is hyperpronation technique, and other one is supination and flexion technique, sir. I think I will involve my orthopedician, sir.
Okay, doctor. So post reduction care, what will you do?
So I will reassure the parents. I will ask the parents to avoid lifting the child or pulling the child uh, by hands or with wrist. I will educate the parents, and I will give the reassurance.
Okay. And follow up, what advice? Follow up advice.
So if recurrent presentation is there, then I will look for uh, other diagnosis like any laxity in the ligaments.
Okay, doctor. 6 minutes over.
Okay, sir.
Doctor, voice is breaking too much again. It was okay, then again breaking.
Acha, my voice is breaking. Huh? Now it's okay.
No, yours and other candidate also, both voice was breaking.
Acha.
Is it
Voice is clear.
I think the problem is not at your end, sir. Like we could hear it clearly.
uh, my voice, Murtaza, is it okay?
Yeah, it was fine. I think is the problem is at doctor's level.
Elizabeth.
It was
Okay.
fine for us.
Okay. Okay. So Srikanth, how you did?
So I think I don't have that much of DD, sir, because and investigation part also, because
It will not have much DD
yeah,
actually.
sir.
sometimes no, the MRCPCH test us in different ways actually. So not to investigate when not needed,
Yes, sir.
investigating the red flags when needed. So I think that all they are checking. So like for example, Bell's palsy comes no always. So what
Yes.
investigation will you do? No, if you keep on adding everything, no, then you are going to lose marks. So no investigation needed. You should have that braveness, courage to say no investigation needed. No, similarly for pulled elbow also, no. To
Yes.
you should have the courage to say that no need for investigation.
Diagnosis, sir, in this type of video station, we need to engage the examiner without saying anything. Like, no investigations, no DDs, no management part other than reduction technique.
Yeah, pulled elbow is a bit appears simpler. Okay. Okay. Others, anybody wants to add to the topic with anything which he missed? The discussion
Right.
part.
What other differential should we put? Like any joint swelling and all? We were not able to make it. Trauma and all.
I
Other
think
differential.
trauma he kept actually. Trauma.
Non-accidental injury.
NAIs. Okay.
Uh, yeah. So as again and again, no. So the non-accidental injury, yeah, like you have to catch the pulse of the examiner. So they expect. So can you please repeat the management? So here, I think as we come, we will discuss the management in detail. Okay. But what DD did you kept in your mind, Srikanth? So one was pulled elbow, the other was fracture and trauma. Third
Yes,
is
sir.
very important not to miss out on non-accidental injury, and it could be a complete dislocation, need not be fracture. Sometimes complete dislocation is also possible. Sometimes it could be just a soft tissue injury alone. It need not be a pulled elbow, it need not be a fracture, it need not be a sublux dislocation, no? Just a soft tissue injury also it could be there. Okay.
Okay.
What else? Can it be septic arthritis?
Yeah, it can be.
Yes,
No,
sir.
Possibility
we
is
don't know.
there.
No,
Can
we
be.
don't know. Only when you ask the history, you know, no, whether fever is there or not.
Yes, sir. Yes.
When you ask that, you will know that no, there is no fever. Whether any swelling is there, redness is there. Again, you have to do the same
So
routine.
as I fixed my diagnosis, my vision is tubular.
Yeah, the once he started doing the procedure, no, so
Yes, sir.
then you felt that way. But keep in your mind. So
Okay.
similarly, when you start in your history, again the same onset, course, duration, progression. Then at that place, any pain, redness, swelling, restriction of movement, then any fever to rule out septic arthritis. Okay, similarly, okay. Then you did ask history of trauma, that was good. And what event led to that? That also you asked whether any pulling happened there. Okay, maybe you could have asked about similar episodes. I think
In the
because you said no recurrent. So in
Yes,
the
sir.
history, any similar episodes that you can ask. Then non-accidental injury. So what all you should have asked? So I think registration to the social worker,
Okay.
bringing the child late. One more point, a good point which I recently saw is for non-accidental. Who is taking care of the child? I think that also is very important, no? With non-accidental, no? So
Yes.
injury that you can do. Then in examination part, so I think you took on the, as always, start with the vitals, anthropometry. Then you start with the same for any musculoskeletal. I will do the screening, musculoskeletal examination, full musculoskeletal screening P-galls. And if I
Okay.
find here swelling is there, so the same I will do the look, feel, move. So you tell that words. So I will look, feel, move. I will check for whether any swelling is there. So here only the tenderness and difficulty. Not the child is just not moving. That position you told nicely in the examination part. Okay. Just the look, feel, move is very important. Musculoskeletal system and look, feel, move. Then investigation, you need to have the courage. I said already, no need for investigation unless two conditions. No, so one, you are suspecting fracture, then you need an X-ray. Then again and again it is happening. No,
Yes.
like not again and again. Failed reduction. You have done the reduction, still
X-ray, X-ray.
once you have done the reduction, it should come back to normal. No, so if there is a failed reduction, then you can go for the thing. Then treatment. What you started with? What in the treatment?
I involve orthopedician, sir. I will inform to my pediatrician also, and reduction techniques, sir. By doing reduction,
Now, what suggestion? I need one suggestion. Who should reduce that? Why can't we do it ourselves?
yes, sir. We can also do.
Sometimes, no. I think they are very much into that. No, you have a communication there also. You're calling the orthopedics and all. No, so they
Yes.
have. There should be some They have criteria. I think they have criteria when you should call everyone. No, so I think this you should. You can reduce yourself. Why you need to involve the
Oh,
orthopedics? No, what
oh,
others say? Murtaza sir, what do you feel?
Yeah, true. And analgesia should be given first.
Yeah.
The child is in pain.
So the safe things, no, to start with. I am a registrar. I am with the basics. So you keep that in mind, no. So
oh,
nil per oral, so analgesics. So those things you consider. Here, no nil per oral, analgesics. At least analgesia. I will look for analgesia. Then you can straight away do the urgent reduction. So what reduction? I think you told the steps, that was very good. Still, if it is not, and you will check for within minutes, the child should improve upon. So then, okay. Then if still doesn't improve, no, then maybe you can take help of the orthopedician. Okay, if the recurrent, when it recurrent, then orthopedician involvement is there. I think you told nicely about the education of the parents, when to come back. So those things were good. Okay, so I think it's simpler case only. Just don't forget the non-accidental injury, and similarly infection, septic arthritis. So these two things, I think they keep on thinking whether you are taking and going with you the red flags. So one is infection, that is the septic arthritis part, and the non-accidental injury and
oh.
malignancy. I would say third will be malignancy. Okay. Okay. So we will move on to the last part. Rohin, you will do part.
Yes, sir. Yes, sir.
Actually, I musculoskeletal over. So this is a bit. I thought it's important. Okay, you take it. Your 3 minutes.
Here. We're not in the room, but we need to get back out there and see. Okay. And then let's turn our hands over and yeah, we can do a. Okay. Now let's see the other hand. Really appreciate you letting us. Now reddish looking in there. You see some dried stuff around there. Okay. All right. Now let's see if I can just get a look at her mouth real fast. I'm gonna clear your lips up. Maybe my here. And then let's turn our hands over and yeah, we can do a. Okay. Now let's see the other hand. Really appreciate you letting us. And a reddish looking in there. You see some dried stuff around there. Okay. All right. Now let's see if I can just get a look at her mouth real fast. Just gonna clear your lips up. Maybe my here. And then let's turn our hands over and we can do okay. Now let's see the other hand. Really appreciate you letting us. And a reddish looking in there. You see some dried stuff around there. Okay. All right. Now let's see if I can just get a look at her mouth real fast. I'm gonna clear your lips up.
Okay.
Okay, sir. Sir, I can see a probably 2-year-old child in a hospital setting, sitting in mother's lap, being examined by a doctor. Child doesn't have any dysmorphic features, no devices attached. Child is not in distress, but is sick looking, and the child is well built for age. But I would like to plot her height and weight in growth appropriate charts. And findings, I can see that the child is sick looking. Child is having conjunctival congestion. There is rashes over her both cheeks. I can see that both her palms are erythematous, and there is swelling of all the digits. And I can see that her tongue is there is a strawberry tongue, and her lips are erythematous. Yes, sir.
Okay, doctor. So, what questions you will ask from the history?
History, sir. I would like to ask about the onset course duration of the rash, and then I would like to ask about any associated fever, any lethargy, any how's her appetite, how's her activity, is there any weight loss? Then I would like to ask about is there any irritability, how's her behavior, any joint swelling, any family history of similar illness, any upper respiratory tract, any viral fever in the family members, any history of allergies, allergies to any drug or any medicines. I would like to ask about any joint pain or any joint swelling.
Okay.
Yes, sir.
Okay, doctor.
Any
So,
lumps and bumps, sir? Any lumps and bumps in her body?
okay. So, what examination findings you want?
Examination wise, I would like to take a vital, sir. Her heart rate, respiratory rate, BP, saturation. I would like to examine her eyes for conjunctival congestion. I would like to see the mouth for strawberry tongue and any oral ulcers. I would like to examine her neck for any lymphadenopathy. I would like to examine the rash, whether it is blanching or not. I would like to examine whether she is having any joint swelling or any features of arthritis. I would like to look at the perineal region for any rash, any reactivation of a BCG BCG scar. I would like to do cardiovascular examination for any murmurs. Also, I would like to examine the abdomen for any hepatosplenomegaly also.
Good, doctor. So what's in your differential?
Differential,
Topmost.
it can be any infectious causes like measles or any meningococcal infection, Kawasaki disease, scarlet fever, any drug reactions, sir? Any drug reactions?
Okay, doctor. So assuming it is a Kawasaki disease, what investigations you want to do?
So basically, Kawasaki disease is a clinical diagnosis, but I would like to do some tests like CBC, wherein we can find neutrophilia, thrombocytosis, ESR raise CRP, then pus cells in urine. I would like to do liver function test where SGOT, SGPT might be increased and albumin levels might be low. I would like to do a 2D echo to look for any aneurysms.
Okay.
I would like to do this.
Continue. Okay, how do you want to manage this child?
Sir, I would like to admit the child. I would check her vitals, including BP and saturation. My team, I would like to involve a multidisciplinary team, including consultant pediatrician, cardiologist, and rheumatologist.
Okay, what treatment? Definitive treatment you want? Rohin, what treatment you want to give?
On IVIG at a dose of 2 gram per kg per day. Initially, I'll start with a slow rate and then looking for any anaphylaxis. If there is no anaphylaxis, I'll increase the dose and give the complete IVIG over the remaining 10 to 12 hours. I would be monitoring her vitals, heart saturation, any flushing of face while running IVIG. Yes, sir. I would also give some antacids to prevent any gastritis of aspirin.
Okay, doctor, time up actually. Okay, Rohin, how you did?
Don't know, sir.
Fairly, you did good. You did good. You picked up nicely. Almost all the history, lot of questions you asked actually. Management also. Actually, this is a bigger case, no? So very quickly you get finished off. Pulled elbow, you didn't have much to discuss. No, here you have a lot of things to discuss actually. So time will go off fast. So as long as you tell from the guideline, you'll get the full marks. Okay. So anybody wants to add to his points? Anything you want to add? He missed.
Some of the investigation was missed, like LDH, ferritin, pro, and BMP.
Yeah. So LDH, ferritin, and D-dimer. Yeah. So extra inflammatory markers, no? So that Aisha is saying. Okay. Anything else?
Should we routinely do these extra inflammatory markers, sir, in KD? Like, if we are thinking, like these are for those conditions in which, like, we are suspecting inflammatory multisystem syndrome, right?
Yeah. Yeah. So
Routinely
if
should be mentioned.
multi-system inflammatory, then we can add to it. But routinely, And suppose we are suspecting hemophagocytosis. So
Ah.
here you can get hemophagocytosis actually.
And we will put it as
We
okay.
can do it actually when you have bicytopenia. So like that, no? So then
Right. HLH, if we are thinking, then we can, right.
then you can add. Okay.
True. Okay, sir. Thank you.
Then if I would give the feedback, mainly I would say one DD. I think you should not miss out as we discussed, no? So that is your multi-system inflammatory syndrome. Rohin, what you feel?
Yes, sir.
It's almost similar, no? So
Yes, sir.
even though the season is not there, maybe you should keep maybe travel to an so in the history travel to an area where COVID is prevalent, but now I think COVID is gone. So maybe, but at least keep in the DD. So maybe it can outbreak anytime. No? So COVID also I will keep in mind if you say that will be good. Then scarlet fever, measles, other viral infections. So I think in the history also you asked very nicely. Anybody else in the family member? So that viral component you try to elicit. Anaphylaxis you try to ask nicely. The drug, especially the rash. Always any rash drug should be the possibility. So drug-induced rash should be kept in the differential diagnosis whenever there is a rash. Okay. Then fever. So in the history, I think all the components of Kawasaki you are going to ask. But in the history, anything related to CVS, did you ask, Rohin?
No, sir, I didn't ask.
So because it's Kawasaki, no? So
Yes.
I think some maybe one or two questions like chest pain or palpitation. For CVS related, you could have asked. But otherwise, I think you asked about the neck swelling, so eyes, any purulent discharge. Then about the rash, did you try to elaborate about the rash in the history?
No, sir, I didn't ask.
So how the distribution,
Distribution, teaching.
any is there or not? So some characteristic related to the rash you can ask. Okay. Then in the examination, I think very important is the vitals, especially whether the child is going in for any shock or not, if it is messy. Rash, I think you tried to look into the distribution. You told very nicely whether it is blanchable or non-blanchable. That's very important because you have to differentiate between the petechiae component from the maybe glass test. You can also talk about glass test to the parents. Then I kept on thinking whether you will come to the cardiac. At the end, you came down. Okay, I will examine the cardiac examination. You told I will look for the BCG site. You told that also nice. Then lymph node and eye examination. So I think in examination you didn't miss out on everything you told. Investigation also you told very nicely that there is no definitive investigation and all the inflammatory markers you are going to do. I'm happy that as per guideline you brought down the LFT, albumin. So those are all part of the guidelines. Maybe even though I have told, so assuming it as Kawasaki what all investigation, still you can talk about ruling out other conditions like virology screening, no? So virology screen, then scarlet fever, your throat swab.
Culture.
So throat swab culture. So I think still, even though I've said assuming it's a Kawasaki, what all investigation, no? You tell all the investigation for Kawasaki, all the inflammatory markers, but to rule out other conditions also because there is no definitive test, right? So to rule out other conditions, I will do the throat swab, then I will do the viral screening. So that management aspirin you told, no?
Yes, sir, I told aspirin 50 milligram per kg.
Okay, good.
Dose.
Aspirin and IVIG. So that IVIG slow monitoring for anaphylaxis. So that all good. And if actually time was over, if time was there, then follow up all I would have asked. So how will you follow up? Suppose there is a single aneurysm. What will you do? 8 millimeter.
We'll continue, sir. We'll continue aspirin till the aneurysm resolves.
Okay. Suppose there are giant aneurysms, multiple, what will you do?
That time, child has to take aspirin lifelong.
Plus anticoagulation.
Anticoagulation.
To also give warfarin also. After heparinizing, you have to give. But lifelong aspirin you have to give. So then you read about all those high risk Kawasaki, incomplete Kawasaki, atypical Kawasaki, all those in the guideline. They might ask you one question suddenly. But you talked about bringing in the rheumatologist.
Yes.
See, again, the same thing. MRCPCH, they have very strict criteria when you have to call the rheumatology, orthopedician, everywhere. So just for any Kawasaki, you are not going to call the rheumatologist. So it's the child is less than 1 year. As per guideline, suppose the child is less than 1 year, you are given IVIG, still the child has not responded like that. So those are when you are unable to manage, then you bring the rheumatologist. Okay, suppose it's a incomplete Kawasaki. You are confused whether it is really Kawasaki. Then you call the rheumatologist. Okay. Then cardiologist, I think you told well. I think fine. Overall session was good. I'm happy that we were able to finish all the 5 sessions. Any doubts?
Yeah, once examiner told that suppose this is Kawasaki, how
Okay.
you are going to manage this one. So
Okay.
in this situation, after mentioning investigation for Kawasaki, I should rule out other also, virology and other things, because it is Kawasaki, he told. So
Yeah.
should I rule out others also by
Yeah.
investigations?
Yeah, I think if you don't say also no issues, doctor. As long as if the examiner has told, suppose it is Kawasaki, then I think relevant to Kawasaki you can tell. Maybe I felt like since we don't have a definitive investigation, 1 or 2 you can tell. You need not tell everything. Maybe scarlet fever, one throat swab, and maybe for virology screening, one. So maybe 2 things you can tell, but need not be elaborately ruling out everything. Okay.
Okay, thank you very much.
Thank you, doctor. Thank you. And before concluding, so if anybody wants to have any practice sessions, you can always direct message me. We can do practice sessions. Similarly, we have a long course going on. We have Murtaza sir, Srikanth sir, Rohin, all in the team. So anybody wants to join the long course also for a more deeper engagement. We are every week we are doing 3 classes. You can join us still. Only 1/4 of the classes are over. Still for the October diet we have. So you can always join us. Okay. So any doubts you can directly message me. Thank you. Thank you, Murtaza sir. Thank you, Srikanth, Rohan, for joining. Thanks, Roshana, for participating. Thanks, Sangeeta. Thanks, Sangeeta, for participating.
Thank you, sir.
Thank you all. Thank you all. I will share the video in the YouTube.